Good afternoon. This is Sarath Kuluru, and I'm going to be talking about a journal for Journal Club this September. So the journal article I picked was a little bit older. It's a 2009 article that was published in Nephrology Dialysis and Transplantation, better known as NDT. It's renal transplantation in systemic vasculitis. When is it safe? And the article came up to me because I have a Wegener's patient who has a living-related donor, daughter who wants to donate her kidney, and they've actually gone through the entire transplant workup, and the transplant surgeon was ready to transplant, but I wasn't sure if it was safe enough at this time. The patient's about 6 months into remission. So I did a quick literature search on this topic, and I found this article, which I found to be very informative, and there's some weaknesses to the article that we'll go through. Now, this article was was written by Mark Little out of the UK. So there's no clear evidence or guidelines on when to transplant patients with ANCA-positive vasculitis. 20 to 40% of ANCA-associated systemic vasculitis develop end-stage renal disease from the glomerulonephritis and end up on dialysis. Now, the questions that were posed in this article are: is there a consensus on how to manage ANCA-associated systemic vasculitis (ESRD) patients in regards to transplantation? How long to wait from induction of remission to a renal transplantation? Whether to transplant an ANCA-positive patient in remission, and whether circulating ANCA have impact on the occurrence of transplant vascular injury. So, about this trial, was full approval for the study was done by the National Research Ethics Service of the UK. So the way they did this study was they sent a survey to transplant centers in the United Kingdom, Ireland, and European transplant centers that are part of the UVAS network. The follow-up with an email or telephone contact survey asked for individual physician's view and not the official policy of the unit. A second survey was sent pertaining to patients that were diagnosed with Wegener's and received a renal transplantation. Data was obtained on each patient, and renal transplant histology was not reviewed, which is a major pitfall of this study. Remission was defined using the UVAS definition, which was absence of disease activity attributable to a BVAS score of 0 on 2 separate occasions at least 1 month apart. So, 25 transplant physicians from the United Kingdom and Ireland responded, and 7 from the European Union responded. Only 6% had an official policy. Only 6% of the transplant physicians that were surveyed had an official policy on when to transplant ANCA-associated vasculitis patients. Now, 100% of all the transplant physicians agreed that patients should be in clinical remission before transplant was to occur. Some of the highlights of this initial survey is: how long should a patient be in remission? Interestingly, greater than a year was 40%, while almost 60% was less than a year, which is quite interesting because we know the risk of recurrence. And how is remission defined? No symptoms in vasculitis was identified by all the physicians. BVAS score of 0 was by 28%, and ANCA negative, interestingly, was 13%. Now, keep in mind now that the UVAS definition for remission does not mention ANCA positivity or negativity, so it's interesting that still some people cling on to this. Some of the other questions that I thought were interesting were: should patients be ANCA negative before transplantation? 16% said yes. And should living-related donor transplants be considered? 93% said yes. So a second survey yielded 119 patients. 12 patients had insufficient data, and we were left with only 107 patients. Interestingly, all these patients were cadaveric renal transplants. This does not So the thing with this is, seeing that my patient will be getting a living-related donor instead of a cadaveric, I don't know how to use this data for my own clinical judgment. However, here's the form here of the questions that were asked. One of the other questions I thought was interesting that was asked is, what's the maximum tolerable level of therapy at the time of transplantation? And so 50% of the physicians were okay with the patient being on prednisone and azathioprine. I thought a higher group of the patients of the physicians would want the patients to be only on prednisone or steroids only, but it seemed like a good majority of the patients were okay with a bit of mycophenolate and azathioprine along with the prednisone. And also interestingly is, how often should how should ANCA be monitored post transplant? And I guess this would make more sense if the patient was was to have ANCA negative or low titers, and then we would follow that. Now, 14% said every 1 to 3 months. 67% said 3 to 6 months, which is interesting because you would probably want to catch a recurrence more likely if you did it more frequently. Now, some of the other side of this table shows the clinical characteristics of the patients that were brought into the survey. Now, 57% of them were male. The age range was from 13 years old to 72 years old. Now, Wegener's was 50% of the trial. Now, the median time of transplant post-remission was 3 years. So, and the number of patients that were transplanted before 12 months of remission was 15 patients. And other notes are 26 of the patients did die during follow-up. What they did is they put people into cohorts. So they had patients that were transplanted before 1990, which were 11 patients, and about half of the patients were, the rest of the patients were between 1990 and 2000, and then after 2000. And you can also see that 25 patients had positive ANCA status, 49 patients had negative ANCA status, and 33 patients were unknown status. And 28% of the patients had ANCA positive in the first year of post-transplant. And interestingly, 19 of the patients, which was 18%, had graft fail before death. And so you go into the graft loss issue. So, and we can go into that a little bit further. So results: overall survival median was 13.4 years for the graft. In all, 26 patients died, which I mentioned before. The survey itself didn't actually ask how the patient died, but some of them included it, and so there was about 5 patients that we didn't know why they died. But malignancy was 6 patients died of malignancy, 4 patients died of infection, 4 patients died of cardiovascular diseases, and 7 patients died of other causes. Patients with remission duration of less than 12 months were more likely to die. 15 patients died who were transplanted less than 12 months after remission and induction. So, of the 26 patients, 15 of them had their transplants done before 12 months of remission. Of the 15, 7 were transplanted less than 6 months after remission. And so we can go into that with this slide here, graciously given to us by Nephrology Dialysis and Transplantation. So you have the cohort. So you don't really have the before 1990, who seemed to not be statistically different from the other 2 cohorts of after 2000 and 1990 to 2000. Now, age of transplant was also an interesting part of this, where you can definitely see you had definitely had an increased risk of death, but not statistically significant with the third tertile, which was greater than 57 years old. Which is to be expected with people under the age of 42, and then people from the age of 42 to 57, and then greater than 57. Remission duration was significantly significant, where you can see greater than 1 year. The probability of death was much less than if you had the probability of death when the remission was less than 1 year when they got the transplants. In overall survival, there was no difference between all the groups. So 5 patients had recurrence of disease, which was about 4.7%. 1 died of lung hemorrhage, and 3 lost graft due to recurrent vasculitis. So 5-year graft survival was at 90%. Actually, let's go back here for a second. So this is interesting to note that 5 patients had recurrent disease. Of those 5, 4 of them lost their kidney and 1 of them passed away. So it's pretty significant. Although we see that recurrence of the disease is low, it's deadly when it is low, when it does occur. So 5 years graft survival rate of 90%. Vasculopathy was on transplant biopsy was significantly associated with graft loss. Now, vasculopathy in this study was defined as any vascular injury to the transplant kidney, including rejection. So ANCA positive. One of the things with this is the study didn't look at actual histology slides or the pathology reports, but if there was vasculopathy, because one of the reasons is because ANCA can be positive during rejection because of a number of different reasons, and I guess that's why they didn't want to parse into that statement too much. Now, ANCA positivity was not associated with graft survival, so we can look at this a little bit closer. So you see here that they had a significant a hazard value of 2.7 for the transplants less than 12 months post-remission, which is statistically significant. Age of transplant, gender, type of vasculitis, all that did not seem to matter too much. So mortality seems to be just with the transplant, the remission length of time as well. And then we can move on to table 4, where you look at the factors associated with the graft failure. And again, you have some bit of leniency towards transplant less than 12 months of remission, but it was not statistically significant. But what was statistically significant was vasculopathy under the transplant biopsy. So we can see that any type of vascular injury can cause the graft failure, which we already know. But it does not have to be due to the reoccurrence of Wegener's or any type of ANCA-associated vasculitis. Now, so you got the vasculopathy, and you can see the statistically significant graft survival. So probably graft failure was much higher if there was vasculopathy compared to no vasculopathy. There was no statistical difference between the different cohorts in the last 30 years or so. Remission duration, again, was not statistically significant, but there was increased risk of graft injury if it was less. Sorry, let me quote that politically correctly. There was a tendency for increased risk of graft failure if the remission was less than a year out. However, this was not statistically significant. So, the ANCA positivity at the time of transplant did not correlate with recurrence of the disease. ANCA was associated with increased risk of vasculopathy in the renal transplant, and ANCA may have effects on the progression of allograft vasculopathy, which I alluded to earlier. So what we have here is we have a very neat graft given to us by nephrology dialysis and transplantation, which you have the patients that were ANCA positive and patients who are ANCA negative. So you have the number of patients. So as you can see, the number of patients with ANCA positive definitely had more severe vasculopathy compared to the patients who were ANCA negative. There were much less of the patients actually having any type of vasculopathy. And this was statistically significant. So if you look at the percent of cases, you have the positive patients with ANCA positive and the ANCA negative patients, and you have the percent of cases, and you see vasculopathy, it is pretty significant, almost in the ANCA positive patients. So let's talk about this a little bit. So there is a consensus amongst physicians who answer the survey that ANCA vasculitis must be in clinical remission prior to renal transplantation, although there was no clear consensus on what remission should be defined as. So at least we know that we don't want to transplant anybody during active disease. Now, 13% of the patients surveyed that felt the ANCA should be negative. However, as we mentioned before, the UVAS definition of remission does not mention the ANCA status. However, ANCA positivity did not correspond to more vascular injury, being it recurrence or allograft rejection. There's no risk of recurrence of the vasculitis with a positive ANCA, but we need to be aware that you do have a risk of injury, vascular injury to the kidney, but graft survival was not statistically significant with ANCA positive patients. Now, 60% of the patients surveyed did not think it was prudent to wait 12 months since remission before transplantation. However, this seemed to be the greatest risk factor for mortality. Now, what could be some of the causes of this? Could this be due to the large amount of immunosuppression in a short amount of time? This patient would have probably gotten 6 months of Cytoxan, and then several weeks later, induction and maintenance therapy would have gotten induced with thymoglobulin or Simulect or something like that. So that would have put a big blow to the immune system, thus having the risk factors of infection and malignancy being on the top of the list of why a patient would pass away. But there might be other causes as well. So there's a lot of weaknesses to this study. It was retrospective. It was a questionnaire based that not everybody filled out and sent back. There was no tissue, no pathology reviewed, and there's always the risk of ascertainment bias. And to remind everybody, the ascertainment bias, which can also be called a sample bias, is where you only report the good cases, the cases that you remember, and other cases are not remembered and not reported. So it kind of skews your data a little bit. So those are some of the bigger weaknesses of this study. Obviously, further study will be needed to ultimately make a decision when to transplant a Wegener's patient. I think that a blinded, multicenter international study that lasts several years is in order to figure this answer out, and powered a little bit higher than 107 patients. If we could get above 250 patients and expand the geography of this would be great. Having plenty of North American patients, plenty of African American patients, and Asian patients would also be very helpful to clinically correlate and to correspond greater to the American population. And so here's the journal itself. And thank you very much. Any questions?